We'll start it. Okay, a 24 years old male presented with left flank pain for 2 days. Left flank pain for 2 days. How you will approach this patient? We discussed it yesterday also. Left flank pain, how you take the history of such a patient presenting to you with fixed left flank pain or left lumbar region pain. How you will take the history? How we take the history of this patient?
Doctor?
Yes.
First, we will ask about his work.
You will not ask about the history of pain? Acha, you want
no, we will ask when did it start?
Okay.
And the grading for this pain?
Yes, complete grading of the pain. Pain's nature, character.
Socrates. Site, onset.
Yes, very good.
Character.
Okay, aggravating factors, relieving factor, everything about the pain. Because you guessed by characterizing this pain, you can differentiate, is it a fixed renal pain or is it a loin to groin colicky pain? That is because of the ureteric problems. So you have to make it fix that, what is the patient's exact problem. Then associated urinary symptoms, and then keep a set of differential in your mind and ask questions to eliminate the differential diagnosis. Okay, this is what we discussed yesterday also. Pain, associated symptoms, urinary symptoms, and then questions to differentiate the different differentials. Now, abdominal examination, what we do in examination, we do a general physical examination and then abdominal examination. And the differentials for acute renal colic are usually radiculitis, so pseudorenal pain, or it could be a leaking abdominal aortic aneurysm. They all present with the same flank pain. Pneumonias, myocardial infarctions, ovarian pathologies, acute appendicitis, testicular torsion, different inflammatory bowel disease, diverticulitis, ectopic pregnancy, burst peptic ulcer, bowel obstruction, any of these can occur with the renal colic with the same problem. So just your patients saying that I'm having flank pain and you say, okay, you have a renal pain and this and that is not enough. You have to rule out these differentials also. Renal pain, and with that ask questions to rule out these one by one or two questions for these. Not all of these, but at least 4 or 5 differentials should be in your mind whenever you take a case. A 24 years old male presented with left flank pain for 2 days, which is radiating to groin. No aggravating or relieving factor, no urinary symptoms, not related to movement, no GI symptoms, no fever. Physical examination reveals left flank tenderness. Now, the nature of the pain is slightly different. When you characterize the pain, patient tells you it is left flank pain and it is radiating to the groin. It is loin to groin pain. Radiation is going to the groin. And now, when you take the complete history, then you investigate the patient further. You do a complete blood count, renal profile, urinalysis, imaging, and imaging. You have to think about which imaging investigation is suitable for this patient. Initially, we go for a KUB. What is a KUB? It is an X-ray KUB, erect X-ray, with specifically taking into account the area of the kidneys, ureter, and the urinary bladder. This is slightly different in its exposure to the chest erect chest X-ray or pelvic X-ray, slightly in between these two, erect chest X-ray and the pelvic X-ray. It is in between these two. We can go for an ultrasound scan, which can tell us about the condition of the kidneys, any obstructing lesions inside, like stones or any abnormal growths. It can tell us about if that obstruction is causing backflow obstruction and causing dilatation of the pelvic calyceal system. We can go for, after that, we can go for intravenous ureterogram or intravenous urography. What is intravenous urography? Through the anti-grade route, through the normal route, we give an injection in the intravenous cannula, through the intravenous cannula. And this, in contrast, injection will enter into the blood, and then it will wash out through the kidneys, and it will outline the whole calyceal system and the urinary system as such. You can see the urinary system starting from the kidneys, and then with the repeated X-ray, you can see the blood, the ureter, and the filling of the bladder. And obstruction at any site can give you an idea that there is some dilatation, or there is some failure of flow of the contrast from the proximal to the distal side. Can you see in the X-ray, do you see anything in the right and the left? What is right and what is left? What X-ray is on the right and what X-ray is on the left? Can anyone tell? Can anyone tell what is X-ray on the right side and X-ray on the left side?
In the left picture, there's a problem with the bladder. Something in the bladder.
There is something in the bladder. And anything else you can see?
That's all I know.
Okay. Any thing you note in the other X-ray, which is in the right side of the screen, or what you can say right side of the screen, or left side of the screen, or on which there is R written? R is written on it. Can you see anything in that X-ray? It's an open discussion. Think, use your brains and think, do you find anything? I said you to look at the KUB, kidneys, ureter, and the bladder. Do you find any abnormal thing in the KUB pathway? And to tell you, it is the X-ray of same patient. Any idea? Makki is here.
Yes, doctor, I'm here.
Makki, do you notice anything in the X-ray on which R is written?
Yes, I see the cyst in the sphincter of the kidney.
Where?
In the left picture.
No.
The upper part of the ureter. So I cyst, calcified.
If I say you to share, sorry, how you can control. Okay, let me. I don't know whether you are getting it or not. I will tell you now. Can you see this spot?
Yeah, this is cyst.
This is not a cyst. This is
stone?
An X-ray, a simple plain X-ray KUB. So what do you see in a thing
stone,
that is,
maybe?
Yes, it is a radiopaque thing. It is a radiopaque thing. Most likely it is a stone. And this is stone. This is the outline of the kidney. If you can see, the kidney is slightly dilated. This is a simple X-ray KUB. And you can see a radiopaque thing here. Now, if you do, this is an X-ray KUB, which is done as a first investigation or first part of an IVU. Then we do the injection and we check the other thing. Now you can see here, there is a normal pelvis. There is a normal ureter with the dye, and the dye is entering into the bladder. Now what is happening on the right side, the same side where we see the stone? You can see that this is the, what is this?
Right kidney?
This is right kidney, which is dilated. This is right dilated kidney. And you see that this is the cutoff point where nothing is going down. There is no flow in the ureter. The bladder is white because the dye is coming from the left side. There is nothing here. Nothing is going down from the right side. Okay. So if you,
yes.
Sorry, there is obstruction. There is complete obstruction, and the dye is not going from the right side into the ureter. Okay, just. Okay, so this is an intravenous urography, and before the urography, we do a plain X-ray to see the difference. Now you see that it is very clear. You may not find anything here. If your eyesight is weak, you may think it is some vertebral column part. It is not a stone, but a hint can be taken from the outline of the kidney. The kidney is slightly big. Now, when we do the IVU, we can see, oh, this is the normal kidney, and this is the abnormal kidney that has been dilated, and the calyceal system is very much distended. And then what is this? Suddenly, there is nothing entering into the ureter from this renal pelvis. So there is an acute obstruction, acute cut down here. Okay. Now you can see another view. You can see this is now magnetic resonance urography, and it gives you more clear picture of the anatomy, and you can see the any problem or any obstruction in the floor, any abnormal thing that is causing obstruction to the flow of the urine throughout its pathway from the kidneys till the bladder. And sometimes if the problem is of the urethra, you can diagnose that too. Now the gold standard for it is CT without contrast. That is the gold standard, and even we can do it in emergency setups also. That gives you a very detailed picture of everything. So for renal stones, renal pathologies, CT without contrast is the gold standard. We can go for CT with contrast, but even the CT without contrast is also very helpful, and it can be very beneficial. Here again, you can see this white opacity. It is a non-contrast view. So what is this white opacity? It is again something that is causing radiopacity is a stone. It is a stone that is causing problem. And then you can see the backflow problem here. You can see the backflow problem on the other side. There is no backflow problem here. The kidney is small. Here the kidney has become enlarged as compared to this side. You can compare the two sides. Okay, so a patient presenting to you with renal colic, treatment is hydration, analgesia, medical expulsion therapy, but it is not very fruitful most of the time. And then you have to make a plan. Would you admit this patient, or would you go for an intervention? Would you like to intervene in this patient? That depends on the patient's presentation and the location of the stone or the location of the obstructive segment. Indication for intervention, admission and then intervention are infection, if the stone is causing back pressure and renal impairment, if there is persistent nausea and vomiting, if there is persistent pain which is not responding to oral analgesia, and if there is a failure of medical therapy. Just wait for 2 minutes. It is azan time. After that, I will start. So these are the indications when we should admit the patient and when should we intervene. It depends on further observation of the patient. Infection, renal impairment, persistent complaints, persistent pain, and failure of the medical therapy. Same patient with the same problem now presents with fever and increased flank pain. And on investigation, you see that CBC is elevated. WBCs on CBC, we have TLC count, the leukocyte count is high. Renal profile is normal, and CT also tells us CT is the same as we have seen before. So what you will do for this patient? Again, now the patient is in an acute condition. You will start hydration, analgesia. You will send urine for analysis and for culture and sensitivity, and the same you will send blood for culture sensitivity. Broad spectrum antibiotics will be started, and if needed, if the patient is having severe obstructive symptoms, we can offer urinary diversion. And how we do the urinary diversion? We pass either a nephrostomy tube. A nephrostomy tube is passed percutaneously and into the renal pelvis, into the dilated urinary pelvis, and then we let the urine pass, urine that is collected there, not going down. We let that urine to pass into the through that percutaneous route outside through the nephrostomy tube. We attach it with the bag. And another way is we pass a double J stent. A double J stent is passed per urethrally. We pass it through the urethra into the renal pelvis, and it make it patent. Sorry. And let the urine to pass from the kidneys to the bladder. Now, in these patients, we have to start broad spectrum antibiotics, and keep it in mind, if the patient is having obstruction, you have to give low levels of antibiotics, because the circulatory level will be high, as most of the antibiotics, they are having a renal route of removal, or they are we can say cleared by the renal route. So if the renal is the kidneys are obstructed, start with a low dose. Keep it in mind that you have to use the antibiotics in a low dose as compared to the normal individual. Same patient presented with fever and increased flank pain, and CBC shows elevated WBCs. Renal profile is normal, CT is same. This patient undergoes a DG insertion, double J stent insertion, and 2 weeks later, when you do check the urine culture, it was negative. What you will do with this patient? He is now having fever, and the flank pain is further increased. Now, as we have said that if the patient is having infection, that is an indication for intervention. Now you have to intervene in this patient. Other indications can be renal impairment, nausea and vomiting, persistent complaints, persistent pain, persistent nausea and vomiting, and if we have started medical therapy, if it is failed. So definitive treatment is we go for ESWL or we go for ureteroscopy. Now, what is ESWL? Can anyone tell? I will try to. Where is it now? I will try to open this video for you, and it will be more.
It's about shock waves, doctor?
Yes, yes, endoscopic shock wave lithotripsy.
Is it about shock waves?
Yes. Wait a minute. I will try to open it in the hyperlink if it opens.
Doctor, is it invasive or none?
Sorry? It is non-invasive. ESWL is non-invasive. ESWL is non-invasive. We are giving ultrasonic waves. And with those waves, we are trying to break the stone. I think I have to.
Your doctor has recommended that you undergo a shock wave lithotripsy. During this procedure, external shock waves are directed to the location of the stones in your body and which break the stones into tiny pieces. When you urinate, these pieces are then discharged from the body along with the urine. This animation shows the removal. There is usually no need for general anesthesia, but pain medication is administered for comfort during the procedure. You are placed on an...
Yeah, just a minute. I will start screen sharing. It was held actually. It was not working.
of the stones in your body, ended that you undergo a shock wave lithotripsy.
Can you see the video now?
Yes, now yes.
Yes, doctor.
During this procedure, external shock waves are directed to the location of the stones in your body and which break the stones into tiny pieces. When you urinate, these pieces are then discharged from the body along with the urine. This animation shows the removal of stones in the kidney. There is usually no need for general anesthesia, but pain medication is administered for comfort during the procedure. You are placed on an operating table with your flank positioned towards the shock wave generator. Imaging with X-rays or ultrasound might be performed to pinpoint the exact location of the stones. Focused shock waves are then transmitted to the stone through the skin. The stone absorbs the energy of the shock waves and breaks into pieces as small as grains of sand. Because of their small size, these pieces can pass easily from the body along with the urine when you go to the toilet after the procedure. The procedure lasts about 45 minutes. If you have a large stone, it is quite common that you need multiple sessions to completely break it. Your doctor will inform you on the needed course of treatment. After the procedure, your doctor will see you for a follow-up to check if the stone completely broke up and got flushed out with the urine. You will be given a urine strainer to catch the bits of stone passed in your urine for further examination. Sometimes a stone fragment can temporarily get stuck in the ureter on its way down. This can cause some blood in your urine, congestion, and even pain. If you are in pain, use the prescribed painkillers and temporarily drink only small amounts to minimize the congestion. Contact your doctor if you develop fever. When the pain is under control, you can start drinking normally again.
Okay, so it is a non-invasive procedure. Only limitation is that we can do it on a specific size of the stones. We cannot do it in stones of any size. The stone size should be 2 centimeter or like that, and then we can offer this ESWL to those patients. This lithotripsy is, as you see in the case, sometime it is very good that you offer this to the patient and then the stone fragments, they pass per ureterally, patient passes these in urine. But sometime one stone piece can dislodge from that position, and it can go and cause obstruction at the ureteric within the ureter. So you have to be aware of these complications. These can occur, and usually they settle with the passage of time. Initially there is edema and there is severe colicky pain, but if it is not the stone is segment is not big enough, it usually passes. Just going to go to the next slide. Or we can offer another procedure to the patient. So I will start it.
What is ureteroscopy?
Or we can offer ureteroscopy to the patient.
What is ureteroscopy? Ureteroscopy is a type of surgery to treat kidney stones. A surgeon does the procedure in a hospital operating room or an outpatient surgery center. Ureteroscopy usually takes 30 minutes to 2 hours. The procedure typically requires anesthesia. However, the doctor does not make any surgical cuts or incisions on the outside of your body. Once you are under anesthesia, the doctor uses a videoscope called a ureteroscope to examine your urinary tract, including your kidneys, ureters, and bladder. The doctor locates the kidney stone and breaks them apart using laser energy, or removes the stones using a small basket. At the end of the procedure, your doctor may insert a small plastic tube called a ureteral stent in your urinary tract to help control swelling and allow the kidney to drain urine. The stent typically remains in your body for 4 to 7 days and is then removed during a follow-up appointment.
Okay, so we can offer this patient either lithotripsy, which is a non-invasive procedure, or ureteroscopy, which is an invasive procedure. Ureteroscopy is we pass a ureteroscope ureterally, and we can offer while we diagnose the stone there, we can break down the stone while using the laser probe, or we can use a basket, dermia basket, to take away that stone from that area, or after that, once the procedure is finished, digestant is placed. Okay, so these are the two procedures that are minimally invasive. One is minimally invasive and one is non-invasive, which we can offer to the patient if the indication is not for surgery. Just a minute. The patient still does not need the surgery now yet. Okay, now if the patient is having bladder stones, patient is having colicky pain, and that is more in the suprapubic region, and that is radiating down to the genitalia region, or the tip of the penis, or maybe into the upper thighs, and it is not settling, and there are indications for intervention, we can go for cystolitholipexy. What is a litholipexy? Litholipexy is just like ureteroscopy. We pass cystoscope, and we visualize the stone, and then we can break that stone using any procedure. We can break it into small parts by using the laser probe, or by manually we can break it, and then it is flushed through the urine. It's flushed out to the urethra with the urine. If patient is having a ureteric stone, just like in the case we discussed in the we saw in the ESWL video, that sometime a stone comes down from the kidney and then it is stuck in the it becomes it is stuck in the ureter and it causes ureteric obstruction. Now we divide ureter into two parts. If it is a problem in the upper ureter, the treatment is slightly different. If it is in the lower ureter, the treatment is slightly different. In the mid or lower ureter, we go for a ureteroscopy, and ureteroscopy is a better option. And because it is more distal, we can remove it easily, and ESWL is not very significant. Now, if it is in the upper ureter and its size is more than 1 centimeter, again, ureteroscopy is preferred because it can take away the stone as such. It breaks the obstructive part and it takes the stone away. We can offer ESWL, another shot of lithotripsy to the patient, so as to make that stone break further and disappear in the urine or dislodge from the ureter. If it is a small stone, then it's up to you, because usually the small stones, they can pass if the edema is settled. If the edema of the edema around the wall where it has been lodged before, if the edema settles, usually patient passes the stone perurethral. But if the patient is not passing the stone perurethral and is complaining of pain, but the stone size is small, it is less than 1 centimeter, then you can go for either ESWL or ureteroscopy. Both have good results in these patients. Now, these were the situation when the stone size was up to 2 centimeter or less than 2 centimeter. We offer ESWL, we offer ureteroscopy. But if the stone size is more than 2 centimeter, we cannot, the surgery has more beneficial role. We cannot get good results with lithotripsy, as the lithotripsy will break the segments, will break that stone into big segments, and that segments can cause ureteric obstruction, and the patient will have multiple presentations and multiple complications. So once the stone is more than 2 centimeter, it is better to go for a invasive procedure. We go for a percutaneous nephrolithotomy. What we do percutaneously, we pass a probe inside, a probe, or you can say an instrument inside, and then we give a alternate way to take away the urine, as well as we try to break the stone also. Sorry. Excuse me for a minute. Okay, sorry. Okay, if it is more than 2 centimeter, we have to go for a PCNL, percutaneous nephrolithotomy. It is a technique in which we remove the stones from the upper ureter or from the kidney. And as the stones are long, they are large, we cannot go for a percutaneous approach, or lithotripsy is not successful here. So how we do it? We open up that area, we open the renal pelvis, we take the stone out, we pass a nephrostomy tube, and we come out. Okay, or we close it. Nephrolithotomy is actually open up of that part of the kidney part. Why we call it percutaneous? Because we are going from the skin down. We are not doing it as a minimally invasive procedure. And yes, once you do it, You have to pass nephrostomy tube also. Okay. So when the stone size is less than 2 centimeter, you have option between ureteroscopy or ESWL. And for this, the thing is you have to look for the location. If it is located in the ureter, better to go for a ureteroscopy. If it is located within the kidney, still in the kidney, we have chances. If it is in the superior calyx, if it is in the superior calyx of the kidney, you can offer a ureteroscopy there also, because we can approach the superior calyx with the ureteroscope, and the stone that we are breaking, they can be easily taken up. But if it is located in the inferior calyx, it is difficult to approach that area. Okay. Any question about it? It's all about the renal stones, how we treat the renal stones. The different management options and different presentation of the patient. Any question?
No, thank you, Doctor.
Okay, did you mark your attendance in the Moodle?